Hi, everyone, and welcome to today's Adult MDS chapter event brought to you by the HealthTree Community for MDS program. My name is Mary Arnett, and I am HealthTree's AML and MDS Community and Education Manager. I am very grateful to have all of you here for our meeting today and for your support in building our MDS community. Today's session will be recorded, and the recording, along with the slides and the resources that we discussed today, will be sent via email to all registrants within 48 hours of the event concluding. We'll start today with a brief Zoom tutorial for anyone who's new to the platform. You can see on this slide how to turn on your camera. At the bottom of your screen, you should see the microphone and camera icons. You can click the video icon that says to start video in order to turn your camera on. We would love for you to turn your camera on if you feel comfortable. We love seeing your faces, and doing so helps us to create a stronger sense of community. With that being said, if you're not comfortable being recorded, you are not required to keep your camera on. Your microphone should currently be off and should stay off throughout the presentation. If you have any questions or comments for us or for our speaker during their presentation, please click the chat icon and type them into the chat box. If you're using a mobile device or a tablet, click the three-dot icon that says More and then Chat in order to turn on the chat box. During the group discussion at the end, you can add questions to the chat, or if you would prefer to verbally ask a question or make a comment directly to our speaker, we encourage you to do so. To do that, if you're using a laptop or desktop computer, click Reactions near the bottom of your screen and then click to raise your hand. If you're using a mobile device or a tablet, you can click the three horizontal dots that say More and then click Raise Your Hand. And now let's get started with today's event. First, I'd like to thank our sponsors who make events like this possible. Those sponsors are Bristol Myers Squibb and AbbVie. And the topic of our event today is, what is genetic testing? What does it mean for MDS patients? At the end of today's event, I'll provide my email address. If you have a topic you'd like to see us cover, please reach out so we can get it on our schedule. We love being able to address topics that our community is specifically interested in. Here is our agenda for today. I will introduce our speaker, and then she will spend the next 30 minutes or so giving us her presentation. After the presentation, we will open it up for questions and comments. So now I'm going to take a moment to introduce our speaker, Dr. Chandhok. Dr. Chandhok is an assistant professor of clinical medicine in the Division of Hematology at the University of Miami Miller School of Medicine, clinical co-leader of the Myeloid Malignancies Program, and member of the Cancer Epigenetics Program at Sylvester Comprehensive Cancer Center. She has a longstanding interest in cancer biology with experience in clinical translational investigation with a clinical focus on the care of patients with myeloid malignancies. Her career goals include improving our understanding of the evolution of myeloid malignancies, identifying disease characteristics that can be exploited for therapeutic gain, and clinically applying innovative therapies to improve outcomes for patients with these diseases. To this end, she has an active clinical trial portfolio that includes investigator-initiated studies with biologically relevant correlative studies, as well as larger industry-sponsored multi-institutional collaborative efforts. Dr. Chandhok is also working to identify pre-leukemic biomarkers that may be acted upon for disease prevention. At Sylvester Cancer Center, she spearheaded the development of a clonal hematopoiesis program to advance the care of patients who may be predisposed to the development of aggressive hematologic malignancies. Within the areas of drug development and cancer prevention, Dr. Chandhok aspires to further our understanding of disease biology in varied populations to provide more personalized cancer care. I'm sure with her impressive resume, you can see why we are really excited to have her on and present for us today. So with that, I'm going to go ahead and turn it over to her.
Well, thank you for that extremely kind introduction. I am just going to share my screen, so we're all on the same page. And thank you all for being here. I really look forward to talking to you and answering your questions. And today we're going to talk about all the basic concepts that you probably have spoken about with your physician, your family members and things like that during your clinic visits, but more with a focus on genetics, where it comes to your treatment as well as the diagnosis. So just a roadmap for this presentation. I will first start with what is MDS, a very, very brief primer. And then how do you diagnose MDS? And this is where a lot of the genetic testing first gets introduced, because it seems to be a little bit of an alphabet soup, but what that actually means. Then what stage am I and how long can I live with this goes along with our prognostic scoring. So we'll talk about how genetic testing can help with that. And then a brief overview of treatments. I'll try and integrate how mutational testing or cytogenetic changes actually influence how we treat you. How do we get the best possible outcomes for patients? And then, of course, I'm happy to answer any questions. So MDS is a disorder of the bone marrow. And basically, our bone marrow is important to produce several different types of cells. Red cells, platelets, white blood cells are the most common things we are talking about in clinic. And usually when patients are presenting, there's an abnormality in one of these or more than one of these. So sometimes patients are, found incidentally while they have labs checked with their primary care, but other times it's vague symptoms like fatigue, malaise, just not feeling your normal self, frequent infections or bleeding that end up prompting an evaluation. And then why does this happen? Well, MDS in general is considered a disease of aging. And why that is that over time, our cells are exposed to toxins. And there's toxins just in the environment, just the aging process itself. You have chemicals that are involved, there's radiation, and then also just stress. And over time, we develop multiple small hits to our genetic matter, which then, if the right combination of errors are created, make the cells somewhat abnormal or dysplastic. That may be a word that you've heard in your oncologist office, where they're saying there's dysplasia. And that's why the word MDS is myelodysplastic syndrome. The cells don't look normal anymore. Now, what this can do is go in a few different ways. One, you stop producing cells, and that causes that anemia, that thrombocytopenia, or the leukopenia in general, which causes those issues I was talking about. Or the alternative is it can progress to either myelofibrosis, which is where the marrow just, becomes fibrotic, meaning it scars over and can't really support blood production anymore. Or acute myeloid leukemia, where these abnormal cells start growing really fast, and, of course, become a more aggressive disease process in some ways, or differently aggressive. So all of these factors are what MDS really is at the core of it. But how different patients, MDS isn't one diagnosis, it is a blanket diagnosis that covers many, many different disease states. And that's what we're going to talk about. And that's how genetic testing helps us. So this is kind of what I was talking about, common issues that we see with patients as they, progress with MDS. One extremely common one is anemia. Anemia is the most frequent issue in patients with MDS. And over time, this means that they require blood transfusions or treatment to try and minimize the need for blood transfusions. That often goes with lower risk MDS in particular. It can happen in both, but that's what we generally think about. And then acute myeloid leukemia, the risk is much higher in higher risk disease, which is something we'll talk about in a few minutes. So basically, these are the key manifestations. So then the next step is, well, maybe you had abnormal blood counts in a primary care office, or you were feeling more tired and that showed that you had anemia, which led to a workup. But how do you actually come to the diagnosis? Well, abnormal blood counts itself are not enough, but often when there's more than one abnormality or certain types of appearances of cells, we become suspicious for MDS. Anemia on its own or thrombocytopenia on its own can be caused by a bunch of other things like viruses, alcohol abuse, certain medications, other blood conditions. So hopefully your cancer doctor is having a really good conversation with you about this. And then, of course, we have certain tests that can help us with, ruling out other reasons that you might have these abnormalities. But then beyond blood counts, a bone marrow biopsy is a pivotal part of our workup at this point because it gives us many different pieces of information that are important both for your prognosis, or that how long will I live or how long will I feel good, but then also in terms of treatment. And so when we talk about bone marrow biopsy, it isn't one thing that we're looking at. We're looking at a whole slew of tests that often come back differently. So sometimes you might hear your provider say, well, the morphology or how the cells look is this, but we're still waiting on, some other test. And that's what they're talking about, because the key components of a biopsy include morphology, where a pathologist is looking by eye at the slides and looking at the cells and saying, do these look abnormal? But then there are many other tests like flow cytometry, which is where they basically take the cells and flow them through a tube and look for, surface markers that should exist on normal and on abnormal cells. But then beyond that, they look at the genetic material, which is something called cytogenetics, which I'm going to talk about in a little bit more detail in a few minutes. And then molecular mutations, which are basically often spot errors in the genetic code, which create these abnormal cells. And then, of course, in that morphology, we're also looking for these abnormal leukemia-like cells called blasts, which can affect the prognosis. So when we're talking about genetic tests in MDS, I first just wanted to walk you through what our cells look like and how they divide. So you may remember this from way back in either elementary or middle school, where you have these chromosomes, and here you can see they're marked in red and blue. And then when the cell is ready for division, they all line up in the center, and the two baby cells take, one piece out of the two. So that creates two identical, two identical progeny or two identical cells at the end product. And then, within those two identical cells, they can make a pair, which can later go on to make an additional cell or additional two cells, actually. But what happens oftentimes in cancer is that, in other conditions as well, but in cancer in particular, we're talking about today, is that when this division is not quite normal, and then if you see in the lower figure here, the more orange looking cell, where both the chromosomes are actually ending up going to one of the progeny or one of the cells. That means one cell will have way too many chromosomes, and then the other cell will have too few. Now, many of these errors, when they happen, the cell will die out. But there are certain errors that the cell can actually survive and can give one of the two progeny an advantage. And that's where you can actually end up with many different types of cancer, but that's one way you can acquire a genetic abnormality. So just those chromosomes, which are not just one mutation or one abnormality, entire groups of mutational data, basically, or proteins and genes are going from one cell to the other. So one of the tests that we do to look at this, and you may have heard the word FISH, it looks for these abnormalities in a very specific way. So we know that in MDS, there are certain conserved abnormalities that can be very important for our prognosis. And one of them you may have heard of is 5q minus, which means that a part of the chromosome 5 is missing. So most chromosomes, as you can see, there's a dent in these, have like a small section and a large section. So the small section is called P and the large section is called Q. And so when you're missing the part of the Q, that's a very, very specific genetic abnormality in MDS. Now, how we look at this very specifically is we have these specialized probes. And as you can see here, one probe is put in the green color and one probe in red. So you would assume that if someone has this entire chromosome, they should have both the green and the red, right? But what happens is sometimes that Q falls off, that abnormality in MDS. And so in this blue cell on the left-hand side, you can see there's a green next to a red for one of the chromosomes, but for the other, the red is missing, which means that that Q has actually fallen off. So this cell has 5q minus, and this is a nice clean readout. Now, the issue with this kind of testing is that we are only looking for the most common abnormalities, so it's not as much of a blanket at looking at basically everything. And so in addition to FISH, we often do something called a karyotype. And karyotypes are basically where you look at the entire chromosomal makeup in about 20 cells, or as many dividing cells as you can find. Usually the number we're looking at are 20. Now, like we were talking about, these chromosomes in that parent cell come in pairs. So as you can see, there are two of one, chromosome 1, 2 of chromosome 2, etc. And this is what normal should look like. So when you hear the words 46XX or 46XY, it's because you have 22 pairs of normal. And then the 23rd is a combination. If you're a man, genetically, you are XY. And if you are a woman, you would be XX. Okay. So basically, sometimes just like you had lost a little piece of the 5, you can lose either pieces or entire chromosomes for in MDS, or you can gain, just like that picture, one cell gained and the other lost, you can gain. So on the left here is just the image I was just showing you, but on the right, as you can see, chromosome 8 is circled, and instead of 2 copies, there are actually 3. So this is a very, very common genetic abnormality that's seen in MDS called trisomy 8. And so when your doctor is talking about chromosomes and, this one is abnormal or that, this is a pretty simple example where there's just an extra copy, but sometimes it's certain pieces of things that are broken or multiple abnormalities. And as a general rule of thumb, this is not an absolute, but as a general, when you have more of these abnormalities, it means your cancer is more genetically unstable, which is generally a bad thing. All right. So then how does this affect what stage am I? And I very specifically haven't told you about mutations or just specific points where, one gene is mutated, because we're going to come back to that in a couple minutes. What stage am I is determining risk, right? So it's important for you as a patient or a caregiver, loved one, to know that MDS is not like solid tumors where you have stage 1, 2, 3, 4, but we divide patients up by risk group. And that actually helps us figure out what the best treatment for them is. And those risk groups include all the factors we were just talking about: the abnormal blood counts, your blasts, the cytogenetic groups, so like the abnormalities that you saw on the test I just told you, and mutations, which is the latest change in our scoring system, which we'll talk about more. And based on that, there's a risk calculator. So if I input all this information from your bone marrow biopsy as well as your labs, based on very, very sophisticated algorithms, it pops out a number. So for example, it may tell me the risk is 2. If the risk is 2, that falls into that lower risk category. The general definition based on IPSS-R is anything less than 3.5 is lower risk, and anything more is higher risk. But even within those, we can break things up into clearer categories as very low, low, intermediate, 1 and 2, and then high and very high. So, in terms of treatment, we just need to know, is it lower or higher? But in terms of actually like parsing out survival, risk of leukemia, all of those, we have much clearer outputs. Now, IPSS-R, which is our historical test that has been used for several years now, uses those groups that I was talking about. And, this shows that that test is really good at telling us how someone is going to do based on all of that information. So the way I look at these tests, if someone's not very good at the graphs, is the more scooped out it is, that means more people are dying earlier. So the blue line, pretty scooped out, right? So that means that a lot of people are dying early on, versus the green line, which looks like a somewhat, smooth downward trajectory. So that people are dying, but they're dying over time, right? And your 50% mark comes much later. So your 50% mark in the blue line, which is the very high risk for survival, is, around 2 years, there's a mark. But for people with very low risk, it can be 6 years or something like that. So the line isn't exactly marked here, but everyone is different in terms of survival. So when you ask me how long am I going to live, this is very much dependent on what the factors are. And remember, many people with a higher risk disease might end up living longer or shorter. This is based on your medians, or, how the average. So we're not perfect. We can't tell exactly, but this helps guide us a little bit. And then the figure on the right shows the risk to AML progression or evolution, which again, as expected, very high risk patients will progress more frequently than very low risk patients. So no surprises there. Now, in addition to that cytogenetics, where you're missing entire chromosomes and whole, swaths of genetic material, we know that there are about 50 very common mutations in MDS. And 80% of patients with MDS will have at least one of these mutations, sometimes two, three, even more. And these fall into these 5 categories. Granted, others doesn't count as a clear category, but we have the tyrosine kinase pathways, the transcription factors, epigenetic dysregulation, and splicing factors. So by knowing what your mutation is, so if your doctor tells you you have a mutation in DNMT3A, I know that that means that there's a mutation in something that is an epigenetic dysregulation gene. And what is epigenetic dysregulation? It's kind of like on your radio, you have an volume. So these sort of genes actually can turn the signaling of some proteins up or down. They can silence a protein or they can make them more effective by little markings on the genetic material. So they're not changing the genes themselves, but they're turning them on and off. Splicing factors are important to modify proteins. And when you modify a protein, the function can be altered. So if there are abnormalities there, you're not modifying things appropriately. Again, tyrosine kinase pathways are kind of on switches that shouldn't necessarily be on for many things. So that's the abnormality there. And then the transcription factors are, and as a part of genetic progression, or, in terms of cell division, you need your old DNA to make new DNA so you can continue to divide. And transcription factors are very key in that process of, creating a new transcript or new genetic material from the old material, and then, the building blocks that are necessary for that. So these are the key general categories. Then there's also, in the others, there are like genes that are important for the DNA damage repair pathway, some genes that are important, for progression and things like that. There are many, or just development overall. So there are many different little classes there, but these are your key areas of abnormalities that have been identified in MDS. And we've known for a really long time now. So if you look back at this figure, which is a lot, but I'm going to walk you through the key things here, is that even back in 2011, when we didn't have like all the panel and all the abnormalities, we knew that having mutations can be prognostic. So in the figure right up top, it's just showing you that same figure in a little bit more detail, where low, intermediate, and high risk patients separate out. The low risk are the black line on the left top, and then the high risk are the yellow line. But if you look at the top right figure, they actually show that if you had a mutation absent, which is the top line, your survival was better. But when you had a mutation of those mutational panel, your survival is worse. So we know that these genes, at least the TP53, EZH2, ETV6, and this rest of this alphabet soup basically can have really important consequences on that information. But remember, the one key thing I mentioned, in the past, we were just looking at cytogenetics and then your labs to figure out your risks. So this wasn't really integrated into that IPSSR that we look at frequently when we're screening you. So why were we not looking at this back then? Well, looking at this in a standardized way was pretty complicated. The reason being is, I told you there are about 50 genes that are frequently mutated, and it's not a single thing. So creating a validated output for something like that is pretty tough. The other thing is these genes can exist at different frequencies within the marrow, so that makes a huge difference too. And in general, MDS is considered a rare disease. So unlike, for example, cardiovascular disease or breast cancer, the number of patients and the number of samples is much smaller. So to validate something so diverse is difficult. Now we know only 10 or 15% of genes are actually mutated in more than 5% of cases. This goes further to talk about the diversity in MDS patients. And then another complicating factor is MDS is itself is a group of diseases, but outside of that, there are many affiliated disorders. And these mutations are actually found in many of those other disorders as well. So it's sometimes difficult to parse out what's coming from where. And that's, something that required a lot to create a standardized prognostic system. And then finally, we can look at each individual mutation and maybe spit out a risk score, but then many patients have multiple mutations. And what does that mean? It often means something bad, but in terms of assigning weight or value to each thing was pretty difficult. So this is still a work in progress, and I believe this will continue to improve. But the most recent iteration of a risk stratifying score has been the IPSS-M, or the International Prognostic Scoring System, which includes molecular. And this type of scoring system includes 31 genes and integrates the information using those genes to determine the risk group. So what did that actually mean? The IPSS-R, which was the test we were using before, created 5 risk groups, and this test has 6 risk groups. So it's basically made it a little bit more refined, but sometimes molecular mutations or patients who would have been scored in one risk group have actually either moved into a higher risk or lower risk category based on the genes we saw. So one really important thing they saw was, for example, if you have a mutation in TP53, which is often a bad player in MDS, that automatically worsened prognosis. So for example, if you were low risk by just the cytogenetics as well as your blood counts, adding that TP53 could potentially make your risk worse. As an inverse, having SF3B1 as an isolated mutation is considered a good thing. So sometimes if you had that, even if your blood counts were quite poor, you may move into a lower risk group, which again informs the patient better about, what to do or treatment and things like that. So all very helpful. Now, a quick aside are these mutations enough to say that we have MDS? Because mutations you can sometimes just check on your peripheral blood. And the key answer here is no, because many people over the age of 60 in particular have a detectable mutation in their bone marrow or just their hematopoietic stem cells. So that itself is an entity which can be considered pre-malignant, called clonal hematopoiesis. But you need those other abnormalities to truly make it MDS. And that's why the bone marrow is still an essential part of our workup. And then these mutations are neither frequent nor specific enough to give us the diagnosis of MDS just based on the mutation. So now how genetics affects treatment options. So the one clear distinction I want to make is, again, we had those 6 risk groups, but for clinical purposes, because the number of drugs we have is smaller, and also just how things work is it's a continuum, is that patients are either grouped into lower risk or higher risk and treated based on this. And I'm going to walk you through the general treatment algorithm and then explain where the genetics becomes important in this, starting with lower risk disease. So oftentimes, if you have MDS and you're absolutely asymptomatic and blood counts are not that bad, patients are just monitored. But as soon as there's an abnormality that's starting to create problems, for example, an anemia, which could affect your heart or your lungs or your kidneys, we're going to want to start treating. And so then it's very problem specific in lower risk disease is that, do you have only anemia? Well, if you have only anemia, we're going to treat you with drugs which are good to improve your anemia. And I'll walk you through that in a few minutes. If you have only thrombocytopenia or low platelets, we're going to either give you transfusions or give you, drugs that can help push your platelets forward or make you make more platelets on your own. And then if you have neutropenia, which is the abnormality of one particular type of blood cells, white blood cell, which is an immune system component, we may give you antibiotics to prevent infections if you are having frequent infections. If you have all of these in high-risk disease, sometimes you may even require, the same treatment or same therapy as people with higher risk disease. So that's what multilineage dysplasia means. That means more than one thing is abnormal, at least in the bone marrow. And so those patients are often treated with a slightly different version of this. But if you just have one of those factors and you fall into lower risk, you're going to be treated for what's bothering you or what's problematic. Now, for higher risk disease or those certain patients with lower risk disease, the most common treatment is this group of agents called hypomethylating agents, which you may have heard of azacitidine or Vidasa, decitabine or Dacogen, and then, more recently Inqovi, which is a cousin of decitabine, which is an oral formulation quite similar. So all of these can be used for the treatment. They're pretty similar, same class of drugs. Different choices are made based on different centers, in addition to supportive transfusions. But one of the more recent changes, this got FDA approved in 2023, was the use of a mutationally specific inhibitor called ivosidenib for patients who had relapse refractory MDS, meaning you had gotten either one of the hypomethylating agents and your disease was progressing still, and you had this IDH mutation, you would be a candidate for an IDH inhibitor, which may actually help, manage your disease. And again, I'll come back to this in a more specific manner in a minute. And then again, for a few patients, if young enough, fit enough from a performance status perspective, can move forward with transplant. But that is, a different entity altogether, which I'm not going to dwell on today. And then again, if you are getting a therapy outside of one of these drugs that I just mentioned, do not panic. Sometimes people have regimens that are derived or extrapolated from data in acute myeloid leukemia, or are derived from clinical trial data before FDA approval for some reasons. So, if you are getting venetoclax in addition, this is a common combination that there are ongoing studies and trials, but also have been used in a cousin disorder, right? So sometimes things are added on for particular processes, but you can ask your provider, like, how is this different or why is this being used? So this is just the entire algorithm altogether, just for conciseness, so you have it. We just talked about all of those. And then, the most common abnormality that people with lower risk MDS have is anemia. And as you saw in that algorithm, there were a couple of different drugs we can use, right? One was erythropoietin stimulating agents, or also called ESAs. You may have heard of darbepoetin and things like that, erythropoietin. All of those are drugs that are used to push your marrow to make more blood. And then the key issue is here, they are used frequently in patients with kidney disease, but for disease like MDS, the dosing is different, where it's a fixed dose that's generally higher than the dosing used for other disorders. And even in tests as, old as these ones, we've found that people who respond best and people who will respond less, right? And one of the factors is actually people who have a subtype of MDS called refractory anemia with ring sideroblasts. And this type of disease actually has more commonly mutations in something called SF3B1, which you've heard me mention a few times. This is a genetic mutation that actually leads to a more favorable prognosis because of a lot of the drugs that end up working. Now, when you have an SF3B1 mutation in combination with a whole bunch of other ones, the impact becomes a little bit more foggy. But if that's the only one you have, that may be really beneficial, because that means you're going to respond to a whole bunch of therapies, including the next drug I'm going to talk about, which you may have heard of is luspatercept. So sometimes patients don't respond to ESAs, or sometimes you can, and more recently, the approval moved forward where people could get luspatercept even if they had not gotten an ESA, one of those drugs I was just talking about, because luspatercept is also very helpful in stimulating blood production. And how it does that is It's basically turns off the off switch. So the technical term here is late stage. It stimulates late stage erythropoiesis. It does that by modifying a pathway called the SMAD pathway. And, basically SMAD is an off button for cell production. So when you turn off the off button, that basically is turning your production of blood back on, right? And that's what makes this drug effective. So most recently, this was last year, they presented the data for, use of this drug in patients who had not gotten an ESA in advance. There is previous data showing, looking specifically at SF3B1 patients or people who have that one mutation. But this trial actually looked at patients with all mutations. And as you can see here, mutational status really matters. So in this red box, I have marked out the difference. It says SF3B1 status at the bottom. And this is showing the percentage of patients who met their primary endpoint, which meant that they became transfusion independent for a longer period of time. And so people who had the SF3B1 mutation, you can see here that, they had like a 70% response rate versus those who did not have that mutation only had about a 44% response rate. So compared to an ESA, one of those prior drugs, the response rate is quite different with luspatercept versus an ESA. But in the non-mutated population, it's a little bit more subtle, not as robust. So again, mutations really do matter, and this is something I'm going to come back to in every context. Now, apart from mutations, sometimes that chromosomal abnormality we talked about in the FISH test is also a very, very key test in MDS diagnosis because it puts you in a completely different category if you have only an abnormality in chromosome 5q or you're missing 5q, which is also called 5q minus syndrome or MDS with 5q minus. Now, why this is important is that we have a drug called lenalidomide, or also known as Revlimid, which is exceptionally effective for patients who have this abnormality in an isolated manner. Meaning, if you don't have this abnormality, there's a very minimal or weak potential for response. But for people who had this abnormality, reaching red blood cell transfusion independence, which is frequently our goal, trying to minimize transfusions, which can be very burdensome for patients. In the they looked at people who were free of transfusions for over 26 weeks. And depending on the dose, about 50% of the patients were basically freed for that amount of time. And the responses lasted a long time too, like a couple of years for many patients. So, this can be a really effective therapy in this one subset of patients who have the 5q minus abnormality, but not very robust for those who don't. And that's why knowing these kind of tests is really important so you can choose the right kind of drug for your patient. Now, when it comes to higher risk MDS, unfortunately, we have a long way to go in terms of developing a new therapy, and we're working really hard to make this happen. But the most common drug or the most validated drug is this drug called azacitidine or Vidasa. Its other cousins, the Dacogen and decitabine, also have the same sort of tests, but this is the one, that we frequently talk about as a clinical trial called the AZA-001 study, where you can see the people who stayed with azacitidine had a better survival. The azacitidine is the blue line versus conventional care, which might mean just transfusions, or it could be some other kind of chemotherapy did much worse, as you can see by that more sloping line. And then, of course, in 2 years, people who were in the azacitidine group had a 55% survival, so half of those patients were still alive, but those who got conventional care or something else, only 15%. So we can say that these hypomethylating agents are effective, but molecular data has actually helped us out even further in parsing out, who might it be more effective in. Now, all patients will generally start with this, because it's like the mainstay of therapy. But I can tell you if someone has mutations in more than one thing, or they have a mutation in something called RUNX1 or ASXL1, maybe EZH2, the same mutations that you heard about earlier, they may have a lower response rate. And so this way, it helps us as your physicians to prepare for, okay, well, this is not working. What can we do next? If that is what it's coming to. So knowing that data may not change your treatment right away, but it does help us be more vigilant in terms of what to do next. And again, I mentioned azacitidine and decitabine, but oral decitabine, cedazuridine, is that cousin in COVID that we were talking about. And this is also an oral version of the same thing. They work very, very similarly. So I hope I've convinced you this is important, and then makes a big difference in terms of me choosing a treatment for you. The last thing I'm going to talk about right now is ivosidenib, which is for patients who've already gotten the hypomethylating agent, but their disease is coming back. They've become more refractory. They're becoming more transfusion dependent again. They're basically not doing well with that anymore. And so if you have a mutation in something called IDH1, you can actually get this oral pill based on, a very, very small trial, just 18 adult patients, where about 40% of those ended up going into remission, and many of those patients actually became free of transfusions again. So even though it's a small number of patients, this same drug has been looked in much bigger cohorts for acute myeloid leukemia. So we feel pretty confident about the side effects. But also here you're seeing that, the benefits can be impressive, and that's why it got approved by the FDA last year. And then again, where does this all come to? Since we have a limited number of approved therapies, oftentimes we're thinking about clinical trials, and many clinical trials are targeted. So I think it's important always to ask your physician if they have the ability to be involved in clinical trials. What options do I have, and what may I benefit from? And some people are pretty nervous or hesitant about this, but clinical trials are basically medicine of the future. So it's important to sort of at least know what's available, because sometimes, before standard of care, there's a newer potential option of adding a backpack treatment on, which may make your treatment more effective. Or if you're progressing on a standard treatment, what else is out there? So these are all important things to consider. Many of these trials are targeted to particular abnormalities, like mutations, like we talked about IDH1. There's also IDH2. There are many, many other mutations where we do a specific trial. We recently finished a trial with the splicing factor mutations. It's important basically just to have the knowledge. Whether you enroll or not is a different story. But I hope you're not very nervous about them, and you should talk about them with your physician. And I'm happy to address any of your concerns in the question answers right after this, but thank you all for your attention, and I'm looking forward to hearing from you.
Thank you so much for that incredible presentation. It was very insightful. I think it really helped us all to understand mutations and what roles they play in care for MDS patients. So now we're going to go ahead and start the question and answer period. I would like to mention that this time is specifically set aside for you to get your questions answered by our speakers. So if you have any questions, please feel free to ask them. As a reminder, you can make your question by typing a comment into the chat box, or by raising your hand if you'd like to ask your question verbally. If you raise your hand, once you get called on, you can unmute yourself and you can ask your question. I did have a patient ask a question ahead of time. She asked, can my genetics change? I have genetics that put me in low risk. Could I then develop high risk mutations?
That's an excellent question. And the answer, unfortunately, is yes. And oftentimes we're looking for signs of that, all the time. So as I kind of alluded to when we were talking about cytogenetics, but less so with the molecular, unfortunately, any type of cancer is what we would call genetically unstable to a certain degree. And therefore, you can acquire mutations, over the time of your having the cancer that can make it then more aggressive. So this doesn't mean that you should always be checking molecular routinely, but specifically at points of change, at new biopsies for response assessment, maybe once a year, it's helpful to have that information, because if your mutations are changing, that could over time affect your prognosis. And so it's good for us as providers to know what is there, because again, that might change your treatment as well. So that's excellent. The answer is yes. But usually there are signs at important, points where you're considering therapy. And remember, the mutation on its own without other abnormalities is not enough for MDS. But once you already have MDS, we're always considering that being as an extra factor on top of, what you already have.
Thank you for answering that question. We have a question in the chat. If I'm treated for my high-risk mutations, does it make it harder to treat AML if I progress?
That's also a really great question, actually. So you shouldn't be treated specifically for your high-risk mutations. You should be treated with those in mind. So for example, if you are getting a standard therapy, no matter who you are for higher risk disease, you should be getting one of the hypomethylating agents first. Now, oftentimes people are pretty excited to do various combinations in the upfront setting, which if logical when you decide with your provider is a good idea. But if there's any sort of doubt, it makes more sense to be fully evaluated and know all your options, because sometimes when too many drugs are added all together without a clear plan, you're right. When you progress, then you might not be eligible for another clinical trial. So it's a very fine balance, because you want to get the best response as soon as possible, but you also don't want to exhaust all your drugs at once if there isn't a clear potential for benefit. So I think that would be best in context with the Venclexta. So the Venclexta or venetoclax can be helpful for people who have disease that is more proliferative or that's growing more. And there is a clinical trial and there is clinical data that about response rates. But does it have to be added for every single patient at this time? The answer is still no.
Thank you for answering that and for clarifying that. I think it's important to recognize it's important to treat the disease as a whole, like you mentioned, instead of just focusing on one thing. We have another question. When I need to receive a bone marrow biopsy for my MDS, what are strategies used to reduce pain during biopsy?
That's a very provider specific thing. So I think the main thing is, again, the pain part is one, if it's anxiety related, maybe medication for anxiety as a one-time thing might be helpful, just to, emotionally, biopsies are pretty stressful. So that's often what I try to figure out with patients. Is it coming from your mind or from your body? And if it's from your body, oftentimes what I will tell people is that, once they get the lidocaine, which is just inserted straight into the site, that the person doing the biopsy should wait like a minute or two for that to fully kick in, and do a little quick test before they, truly get the biopsy sample, because you're essentially responding to the change in pressure as opposed to the normal stimuli for pain. So by doing that, you can hopefully have the least painful biopsy. Now, things that sometimes can make a biopsy from a biological perspective more painful is that if you're packed full of abnormal cells or blasts, or if you have something called marrow fibrosis, which are these little fibers in your marrow, and then they try and suck out the aspirate, just that change in pressure can be painful because there's more stuff there. So different strategies, of course, there's always the interventional radiology where they knock you out kind of route. I try not to do that as much as possible, I'll be very honest, because sometimes that can affect the quality of your biopsy. But there are absolutely ways to make things more relaxing depending on who you are and what the issue is. And then
Thank
post, it
you.
makes sense to take maybe Tylenol for 24 hours if you feel like you're sore after, but it should be like a bruise.
Thank you for answering that. I think that's something that comes up pretty often, that anxiety around the biopsy. So I think those
Mhm.
strategies are helpful. And then I had one more pre-submitted question. And then if we have any other questions from anyone here live, we'll make sure to answer those as well. The pre-submitted question was, is there a reason a doctor wouldn't test for genetics? My doctor didn't. Does it mean that they think I'm low risk?
The answer to that is no. In the modern MDS space, there is very little reason to not test it. You should feel empowered to ask them why. Maybe it was that they weren't expecting MDS in the first pass, so they can get genetic testing off of your blood. But it would be a really helpful aspect to know because blasts, which is often things people who are treating MDS who have a little bit less familiarity, they're looking at blasts or no. And of course, that's a really important thing. So morphology still goes a very long way. Some of our old tests are still super important. But these fine, nuanced decisions you make are often based on molecular. And molecular may not change your treatment, but if there's even a chance that you can get a less toxic drug, I think it makes sense. Like, for example, if you have an abnormality in SF3B1 that might actually make your prognosis better, or a mutation in TP53, which may make your prognosis worse, I think you should know about it in terms of, for everything in life, beyond treatment, planning what's the next step. It's kind of important. So I would definitely urge you to ask them to test. And, if they're not sure, they don't know what to do with it, sometimes you can have a consultation at a specialty center, where your doctor does only MDS or basically the myeloid diseases, because one of the problems with being a relatively rare disease is sometimes unfortunately, providers are put in a place where they're treating something they're a little bit less familiar with.
Thank you for that answer. I think that will be really helpful in providing this patient with the confidence to ask their doctor. So I think that will be really valuable feedback for her.
Mm-hmm.
Looks like that is all the questions we have today. So I am going to move ahead and just want to again say thank you for your presentation today. We really appreciate all the time you spent preparing for the event and your time presenting and answering questions. I then want to take a second to announce some of our upcoming events we have. So we have an event on May 30th on dietary guidelines for cancer prevention. We then have an event on June 27th on MDS and MPNs. They're going to look at what are MPNs. I think that's something people in our community hear. So what are MPNs? How are they similar or different from MDS? Kind of get into that. I'm really excited about that. And then we'll have one of our MDS community members on in June to share his story. Another event coming up I'm excited about is an event on July 1st on barriers in healthcare with some solution to those barriers with Dr. Knight, who dedicates a lot of his research time to this topic. I'm really excited for these upcoming presentations, and I hope to see all of you again at these upcoming events. You can visit the link that's at the bottom of this screen to register for those. I again want to take a moment to thank our HealthTree for MDS sponsors, without whom events like this would not be possible. Those sponsors are Bristol Myers Squibb and AbbVie. And finally, I just want to say thank you to all of you here for helping us to build our HealthTree for MDS community. Please don't hesitate to reach out to me if you have any questions about HealthTree or if you have any topic you'd like us to cover in one of our future webinars. We would love to make that happen for you. Also, if you would like to share your MDS story in one of our webinars, please reach out. We would love to highlight our community members to help others through hearing about a peer's experience. I appreciate all of you, and I hope you have a great rest of your day. I hope to see all of you again soon. Thank you.